Good evening, colleagues. It's my pleasure to welcome everyone to our Spring 2022 BU School of Social Work Equity and Inclusion Speaker Series event, co-sponsored with our clinical and macro department, Disability, Race, and Gender Toward Sexual Health Equity with Natasha M. Lee Johnson. My name is Ellie Zambrano. I am the Executive Director at the Center for Innovation in Social Work and Health at BU School of Social Work. I'm also a member of the BU School of Social Work Equity and Inclusion Committee, which includes all of our stakeholders, faculty, staff, students, administrators, and alumni. The committee has been around for many years, engaging in the work of building equity, inclusion, and justice here at the BU School of Social Work, as well as amplifying social justice focused activities here in the community. Some of the work we have engaged in includes organizing social justice learning communities, creating social justice focused case consultations, partnering with different departments around social justice focused interventions, student support and solidarity circles, and a field department social justice seminar. We also have wonderful resource pages available to everybody that includes podcasts, peer-reviewed literature, and media articles that I encourage you to check out and share. Finally, we have just completed a 3-hour online module on structural and institutional racism that's now available to anyone in the world for free through our Network for Professional Education. You can access many of these resources at our Equity and Inclusion website. I'm going to briefly review our format for today. I'll introduce Natasha, and she will present for about 30 minutes. We will then have 2 members of our BU School of Social Work community offer a 1 to 2 minute reflection about the talk and ask Natasha a question. Finally, we'll be able to answer a few more questions from the audience that you can type directly into the chat. A quick review of a few Zoom housekeeping items. Anyone who is receiving CEUs will need to keep their camera on during the entire session. If you're not receiving CEUs, we recommend turning off your camera during the talk. If you are receiving CEUs, you will need to complete the evaluation form. We will type the link to the evaluation form in the chat at the end of the presentation. We suggest having your Zoom setting on speaker's view. We will be recording the presentation, so if you aren't comfortable being recorded and you aren't receiving CEUs, please keep your camera off during the entire event. We will be posting the recording on our Equity and Inclusion Speaker Series page a few days after tonight's talk. All participants will be muted during the presentation. Please do not use the chat during Natasha's presentation, as it can be distracting for the speaker. Closed captioning is available for the presentation. To use closed captions, you need to click on the closed caption button and choose Show Subtitle for the captions to overlay on their screen. Finally, it goes without saying that all comments in the chat should be respectful and mindful of our entire BU School of Social Work committee. We would like to begin our presentation with a land acknowledgement. A land acknowledgement reminds us all that colonization is an enduring reality and that Boston University sits on the stolen traditional lands of the Massachusetts people. If you're outside of Boston, take some time to learn about the tribal lands where you live and the ongoing movements to have land honored, acknowledged, and returned. These past 2 years, we've witnessed the cruel outcomes of our current social, political, and economic systems, with COVID-19 unmasking the devastating long-term effects of gender inequality, anti-Asian violence, ableism, and racial capitalism. The timing of Natasha's presentation couldn't be more appropriate for our historical moment, where we as social workers, part of our world community, stand at a crossroad. Our speaker tonight, Natasha M. Lee Johnson, is a social work doctoral student at Louisiana State University, who's studying sexuality and reproductive health among Black women with disability. She has served in leadership roles that support health equity for women and people with disabilities and was named a Robert Wood Johnson Foundation Health Policy Research Scholar in 2021. In addition, Natasha held 2 fellowships with the Association of University Centers on Disability Network. She is driven by her personal connections to disability justice and professional observations and engagements with reproductive healthcare systems. This presentation focuses on the reproductive health crisis among Black women, especially those with disabilities, by exploring the links between disability, race, and gender, and structural barriers to reproductive justice in the United States, focusing on strategies for social workers, healthcare providers, researchers, and educators. This talk will highlight ways to create change in pursuit of reproductive justice for Black women. We are honored to have her speak with us tonight. Please join me in welcoming Natasha M. Lee Johnson.
Hello, thank you. Thank you for that wonderful introduction. And let me just get set up. I know we've all been doing Zoom for a little bit now, and yet I'm still figuring it out. So. All right, how's it looking? Are we good? Wonderful. Again, thank you. I'm so excited to be here today to talk about disability, race, and gender, particularly as it relates to sexual health equity. However, before we get there, I would like for you all to commit to one thing for me. As you listen to the presentation, I would like for you to try not to judge or think about the degree to which you may disagree with the information being presented. Rather, listen to it, follow the logic, and consider how the concepts might fit together to inform your practice. All right. And so now we shall begin. I wanted to take you on the journey that moves beyond land acknowledgements to briefly share 2 initiatives. As the land acknowledgement talked about, there are a series of movements going on, and one is the Land Back movement, which is an Indigenous-led movement to transfer the political and economic power over public land to Indigenous peoples. This movement does not require that occupants leave their homes. Rather, it is about the transfer of governance to Indigenous leaders. And so I really like this movement because it imagines a future where Black reparations and land back can coexist. In addition, I want to highlight the Black Mamas Matter Alliance, which is a cross-sector alliance that has driven much of the research that I'm going to present here tonight. There's also an upcoming conference, and there's opportunities to submit abstracts for those who are interested. So if you're really interested, I encourage you to submit an abstract or attend. All right. Okay. So I mentioned that I wanted to take you on a journey. So I am going to present a series of maps in order to do 2 things. One, I want us to reflect on the land that we occupy, as that land is a key thread throughout my presentation. Land politics is a key thread. Typically, I do an activity with my students where I show them a series of maps and I ask a few questions. So who have seen this map? And typically, not surprisingly, many hands shoot up. I've seen this map. And so I ask them to look at some characteristics of the map. What do you notice? And so typically we notice that the US is in the West and the Americas is in the West and Asian countries is in the East. We also notice that Europe is positioned in the middle and on top. And this is called the standard world map. Next, I present this map and I ask my students, who have seen this map? Fewer students frequently raise their hand. And together we repeat the same process. We notice that now the Asian countries are on the left and the Americas are on the right, or the East and West have kind of flipped around. And so we joke that to fly to, let's say Japan, you have to fly out of LAX. So you're going west to go east. But it's funny how that works. We're all in a big sphere. So this is the Asian world map for the most part. And then I show this image, which is the Australian world map. And we talk about what are some things that folks notice. And right off the top, it's all, well, first of all, many people haven't seen this map, but off top, we notice that the map is flipped upside down. And what Canada and Russia, they look more shrunk. And we also notice that Australia is in the middle and on top. And so we can conclude a few things from this. We can include that maps, that all continents on those maps want to be centered and want to be on top. We live in a sphere, like I said, so this can divide East and West and North and South. And so really interrogating who gets to make those distinctions. So I asked my students, why is this the standard world map? Why is this the one that we're most familiar with? And today, I offer a simple explanation. White supremacy, a Eurocentric culture that positions white folks and whiteness as a standard and all people of color as deviations to that standard. And I argued that by understanding white supremacy, we can begin to comprehend health disparities and pursue health equity. And so for my students, I've developed a conceptual model to help them really understand how white supremacy infiltrates our social identities and social structures. So white supremacy uses two tools, capitalism and patriarchy, to position itself in all of our structures. So education, employment, housing, health. Housing and health is what we're mostly going to talk about today. Legal, media, military, and all of these structures are reinforcing one another. So they interact and they engage and they reinforce white supremacy. And on the other hand, we have interlocking identities or interconnected identities. Now, you may have heard of intersectionality, which is a particular kind of interconnectedness. But for this purposes, we're going to use interlocking. And so we see that white supremacy infiltrates race, defining who gets to be white when they enter the US, or who gets to be Black, defining gender binaries. Prior to white domination, binaries did not exist for gender. Thinking about disability and how it erects barriers that prevent resources from being accessed to people, and then so on, class, sexuality, age, and immigration, all these things interacting, and then also talking to one another. People engage with systems, and systems also engage with people, frequently through laws and policies, creating structural and interpersonal racism, sexism, classism, and all the other isms we're seeing. So I want us to be on the same page when we start to think about how white supremacy underscores some of these health disparities we're seeing. And then particularly when we think about health, and I'll go through this really quickly, we're really talking about healthcare, public health, tribal, and private industries, anybody who kind of engage in health and health resources. Okay, so here we are. Black women and disability. What does it mean for Black women to be disabled is the purpose of this slide. So when we talk about interconnectedness, we're talking about how identities are co-constructed, which is kind of complicated. So I'll explain it through 3 communal knowings that you might be aware of and may not, and so it may be some new information. So when we think about tropes like the strong Black woman, this is the myth that Black women are uniquely strong, able to endure pain, can surmount very difficult task because of their sheer will and innate ability. And through this view, Black women are disallowed disability. They're not able to engage with having a disability. And so their identities or their survival is depoliticized. We also see a second very prominent teaching in Black communities is that you have to be twice as good to get half as much. Scholars Bailey and Mobley writes that while designed to protect Black children against profound racism that is masked in the masquerade of meritocracy, it marks the difficulty with discussing trauma, health disparities, psychiatric, physical disabilities within Black communities. So basically, when you think about these two myths, you have a group of people who are valued for their strength, their excellence, their productivity, leaving little room for disability, discussing challenges related to disability, and let alone advocating for accommodations. And then third, you have this idea of being fast, whereas Black girl bodies are hypersexualized, so their bodies are often surveilled and judged and seen and deemed as too developed or too curvy, thereby in a lot of ways making them responsible for their own sexual violence that they may experience. Okay, so as we move from white supremacy, we move our discussion along from white supremacy to health disparity, I do want you to keep white supremacy in the back of your head because it does underline the health differences for Black women and those with disabilities by creating economic, social, and environmental disadvantage. Specifically, white supremacy is showing up through those isms we talk about and manifesting in our built environment. And the built environment really structures access to resources like jobs, health in hospitals, green spaces, healthy food, and also exposure to things that are really detrimental to us, like air pollution and concentrations of fast food and alcohol outlets. And so the built environment really affects our health. Okay, and so when we think about housing, we may think about Jim Crow to redlining to white flight. Black people have overwhelmingly been relegated to least desirable and least safe housing conditions. And now if we consider a contemporary issue like gentrification, we start to see clear threads that may lead to areas with fewer resources and more exposure. And those factors are contributing to obesity, hypertension, fibroids, heart disease, which are all associated with pregnancy complications. There's a recent study where I live in Louisiana that shows, a 2021 study that shows the role of racially segregated neighborhoods increasing risk for pregnancy-associated deaths. So it's a thing. And so when we, when we start to think about pregnancy-associated deaths and mortality, nationally, we see that Black women are 3 to 4 times as likely to have a pregnancy-related death as compared to white women, even when controlling for education and income. And then one study, when controlling for social determinants that I just talked about, Black women were still dying at 2.5 times the rate of their white counterparts. So that suggests that racial discrimination is really shaping, in addition to built environment, racial discrimination is really shaping the interactions between medical providers and stereotypes and implicit bias and mistrust. And there's a lot of things interpersonally that's also going into these rates. And then Louisiana, so those are national estimates. In Louisiana, Black women are 5 times as likely to die. And in the South, and that mirrors the South in general, of like the desperate rates. And so, and of the many women survive though. And of those women who do survive, then thousands are likely to have short-term and long-term disabilities. And so we're still really starting to see how this maternal health crisis intersect with disability issues. And so I picked about 3 different things I want to describe. And I thought abortion rights was very important. Back in December, the Supreme Court heard the case that centers around a law in Mississippi that aims to ban abortions after 15 weeks. And so the courts are expected to make a decision late spring, early summer. And a very real potential outcome of that decision is that the Mississippi law is upheld, and Roe v. Wade, which gave everyone constitutional right to pre-viable abortions, can be challenged. And so this effectively erodes the right to pre-viable abortions. It turning abortion rights over to states where geography will even more so than ever determine reproductive choices, and leaving room for more restrictive bans like the 6-week abortion bans. And so in this, you can tell I like maps. In this slide, I wanted to just show the number of states that have trigger laws. And basically what that means that if Roe v. Wade was overturned today or tomorrow, the states in blue are the states that would virtually ban abortion, period. And then the states in yellow and orange are the states that have the 6-week ban that would be made effective immediately. And so one thing you might look and notice and see that Southern states are the most colored here. And so we need to consider that 55% of Black people live in the South, in the country. 55% of Black people who reside in the US live in the southern region of the country. And so Black women have an invested interest in abortion rights, particularly as you think about how Black women's bodies and reproduction has been controlled and suppressed and surveilled like livestock since chattel slavery. When you think about the mortality rates that we just discussed, pregnancy and childbirth is life-threatening for Black women. And when we also think about Black women, 70% of pregnancies in Black communities are unplanned. And then Black women also make up 38% of abortion service users. And so like voting rights, Black women are exercising their rights to abortion. And this is my last disparity that I want, even though there are tons, I just wanted to highlight a few in our time today. But in the past few years, and I wanted to do sexual violence because in the past few years, sexual violence has been elevated, Me Too, Time's Up, all those. But there is still a lot of work to be done and support that's needed for Black and disabled people. Some things that we know to be true is that 40% of Black girls report experiencing coercive sexual contact prior to age 18. And what's more is that 1 in 5 Black women are survivors of rape. And for every person who report rape and sexual assault, then it is estimated that 15 women do not report. So those numbers are alarming. Even so, people with disabilities have not received a lot of attention around this issue, and they are very vulnerable to sexual assault and violence. And so some estimates put that women with people with disabilities are 7 times as likely to be sexually assaulted. And then 83% of all women with disabilities will be sexually assaulted in their lifetimes. And now, follow me here, there is no data, at least that I can find, about the prevalence of sexual assault for Black women with disabilities specifically. However, from these figures, we can imagine that number is egregious and alarming and cause for concern, particularly because that the group is positioned at the intersection of Blackness, womanhood, and disability, experiencing racism, sexism, and ableism all at the same time. And so as we move along our journeys, I want, excuse me. As we move along the journey today, I want us to lean into health equity to shape our solutions to reducing and eliminating systemic barriers in the health, and then also eliminating the determinants like air pollution, those types of things. As many of these deaths and illnesses are preventable, the US could avoid about 40% of maternal deaths if women, regardless of age, race, zip code, had access to quality care. Also, improving healthcare access and quality, government folks, policymakers need to address the root cause of Black maternal death, and that includes white supremacy and all the things that it produced: income inequalities, racial discrimination in healthcare, and beyond. And much of this really lies at the hands of policymakers, and still, I think that researchers, educators, and service providers, social work service providers, can align to support such an agenda. And so I propose a few things. Okay. So it is important to move beyond health equity and health disparity to health equity. So move beyond describing the problem to addressing the solution, because there's a lot of evidence that show there's a lot of problems, right? And ways that I think researchers can start to get at this is by situating their work into appropriate theories that can explain the difference between white supremacy and health outcomes to get to those sustainable solutions. And there's a lot of rhetoric around engaging in ethical practices, citation practices, and citing and incorporating Black and disabled people's scholarship into their research. And we can talk a little bit more of time. And then also utilizing accessible methods and population level research methods. And so not discounting those very more like case study or more qualitative, I should say, methods like autoethnography, sister circles, but then also like needing to show that this is like these solutions are working at a population level by using geospatial analyses and multi-level modeling. Collecting data, this is the biggest problem I've seen. So we need to collect data on disability, and this specifically, we need to, excuse me, my mouth's getting a little dry. Okay, we need to collect appropriate data by disability and type. If you recall that sexual violence slide where we didn't have any data about Black women with disabilities, if we aren't tracking data, then we can't see the disparity and we can't get to the solution. And so we need to disaggregate that data by disability type. And we mentioned that Black women have been excluded from disability discourse. So a simple, do you identify as disabled, will not cut it. And the last thing I want us to talk about briefly is community. We need to treat community members as partnerships. And this is a talking point that I've heard several times, but I've also witnessed that it does not happen. Treating community members as partnerships. I have a story about a colleague who wrote a grant, an upper bound grant, got the grant funded, everybody was happy, went to the schools to talk about partnerships and what that looks like. principals are completely overwhelmed and don't want to give time to talk about how to implement this grant, right? And they wonder, hey, I have $1.1 million over the next several years. Why aren't they talking to me? And it's because no partnerships were established in the beginning, right? You wrote a grant, you saw a problem, which is great, which is well-intentioned, and you wrote a grant, and community members have no obligation to help you fulfill that grant. And so it's important to have buy-in. We also need to build on skills that communities have. So for instance, you write a grant and it gets funded, and the grant money is going to run out at some point. So how do we sustain communities in a way that's appropriate? We can't be in the business of just writing grants for career advancement, not as social workers. And then also, I would say improve accountability and integrity for community-facing work. This is, and what I mean by this is frequently social researchers are contracted by government entities to evaluate a community intervention. And while the researchers do get IRB approval, the research that's generated is not subjected to peer review processes necessarily prior to that information getting sent back to the health department or sent to the community. And so that means that the evidence that directly influences the community can be at minimum misleading and at maximum fabricating. Thinking about service providers and things that we can do to support Black women and their reproductive health. And one of the big ones is trust Black women. Trust Black women when they say they're in pain. Trust Black women when they say that they need help. Trust that they understand their bodies. Also, you must build the capacity to help them build the capacity to be informed. Too often, I think providers, social workers, whomever, becomes paternalistic in a way that sometimes they justify sometimes they can justify to not get informed consent. And then also honor that autonomy. Like if you're a person who's like not for abortion and your client is saying, I want abortion, honor their autonomy. Or if other way around, if you're like, this is not a safe situation, are you sure? Honor what people are saying and be flexible with canceling mixed appointments. I know that particularly when you're in private practice, time can be money, especially when you're not working for a provider, an organization, and you're on your own. But be flexible with missed appointments, especially as it relates to fees. Thinking about programs that you do in communities, we want programs to be high visible. Sometimes I think like food pantries, we try and keep them in the back corner because there's a stigma associated with them. But I encourage you to have those resources as high visibility. Some of the best community service events I've gone to has been on like main streets where people just like pull up and get a food box, or pull up and get a COVID test in their nose, or pull up and get any other type of resource. And then involve community faith leaders and politicians. I find that there's so much discourse around politicians and like career politicians, and politicians are corrupt, but particularly in the South, where the region is very Black and politicians are often careers, specifically at the local level, like the state level. And so needing to rethink how you can engage those people who are career politicians, because they are career politicians for a reason. They have some type of connection, they have some type of resource, some type of way to get people to vote for them. That means they get voters' information some kind of way. And so those are people that need to be on your side. And then offer those like material supports, like I said, like the COVID tests and the food boxes, but also seeking structural change through policy reform. And then last, for the resources, I would say, think about your curriculum as a social work educator. Disability cuts across all social identities. It's shaped by all social structures. And I frequently tell people that if you live long enough, you will get a disability. So you need to have a vested interest in how people are being treated and how people are accessing resources and services. So incorporate disability and maternal health into your social work education through things like reflective assignments. Think about your methods that you're doing that. One thing that you can do, but you shouldn't do, is teach about disability and accessibility and not be accessible yourself. So you might consider the way you give assignments rather than traditional papers. Do you allow podcasts? Do you allow videos or class policies and laptops and attendance? Things like that that you may consider to change. And then finally, breaking down the classroom and to the walls, the confines of the classroom to invite community in for reciprocal learning. Whereas, like, if you're giving a presentation about something that's helpful, that might help community members, invite them. Whether it be Zoom, invite them, right? We can't sit in an ivory tower and gatekeep information from people that we want to help, particularly if we want to be health equity researchers and scholars. And then get students involved in those organizations and also do an internal climate survey. Is your program really accessible for people with disabilities? Is it really? And in what ways? And then if you do an initiative to make it accessible or make it less racist, then making sure you're having ways to evaluate that as well. And not ways that's just like, we offered safe space or we offered this. Like, how did people tell you that this is working for me? This is a good climate. My last offering is, while my presentation has been heavily focused on structural inequities, I also wanted to offer some interpersonal things that you may consider. And I do this because it's important to be not only ethical in your professional work, but also interpersonally. Dr. Brittany Cooper, the author of Eloquent Rage, reminds us that it doesn't matter how many Black women you cite and you include in your study, if in real life you treat Black women like trash. So I encourage you to engage in a reflexive process that enables you to identify and cope with your privilege, so that you understand that privilege is a power granted by white supremacy, and having the tools to emotionally deal with your positionality to white supremacy. And I'm not specifically talking about white privilege. I'm talking about a lot of different privileges that white supremacy grants. Okay. And then the other one, what I would say is, please stop gaslighting. If you are gaslighting your colleagues, particularly thinking about how people speak up in meetings about race and racism and are met with radio silence in the room, right? And so sometimes I know I've experienced it. I'm speaking up against racism and met with radio silence from my peers. And then people pull me to the side and say, after the meeting, and say, oh, that was so great. I really appreciated what you had to say. And I'm like, well, thank you. It would have been nice to have that support in the meeting. So try to not do that and stand and show up for people. The other one I would say in terms of gaslighting is this idea of not being able to find qualified Black candidates or qualified candidates of color. I think it's a straw man in that when you consider HBCUs, historically Black colleges and universities, do it every day. And so maybe it's an opportunity to take other leads of other schools. Like, what are those schools doing right? Obviously, they're doing something right, and they're creating a climate that retains them and attract more people, attract more qualified Black and people of color. And then my last offering would be that I think too often we encourage social workers to draw boundaries around social work values and personal beliefs. But if you're truly doing health equity research, you should be personally ethical as well. And so that includes voting in ways that dismantle white supremacy. And I truly believe that the job of a social worker is to work into, there is no need for social work. Okay. And at this time, I will accept questions. And if you're like me, then you likely have more questions than what you started with, and that's okay. My hope for the presentation was that it enabled you to have better questions and be more critical. So, thank you. All righty, I'll accept questions or reflections.
Natasha, can you take your slides down for us for a second, please?
Oh yeah, absolutely. Stop.
Thank you, Natasha. Your presentation was so informative and so helpful in providing examples on how to walk the talk in terms of the value around equity and inclusion. I'd like to introduce now our first reflector, Rihanna Howard. Rihanna is a first-year doctoral student at the BU School of Social Work with an interest in researching how the incorporation of trauma-informed practices into education systems can improve the mental health of marginalized youth and decrease the trauma caused through the education process. She's also interested in researching how school discipline practices among students of color and carceral logic upholds the school to prison pipeline.
Perfect. Thank you for that introduction. And thank you, Natasha, for your presentation. I really appreciate the journey that you took us on and taking us from the 3 different modules and showing us how white supremacy impacts and creates and upholds systematic oppressions, especially for Black women with disabilities, and healthcare, and frankly, every system that you mentioned throughout your presentation. I also appreciate you talking about communities and community involvement. And my question for you is looking at, so a lot of my family members, my sisters and friends who are interested in motherhood have had negative experiences within the healthcare and have in turn started connecting with communities and working with doulas and more holistic medicine to hopefully appreciate and take care and have trusting relations with the people who are a part of their motherhood journey. And so I'm curious to see how doulas and holistic medicine, specifically within Black communities, has impacted those disparities or decreased gaps within those disparities of women, Black women, and disabilities and motherhood and birth giving.
Thank you for that excellent question. I had an opportunity maybe last year around this time. There's a representative in Louisiana who's trying to put forward a policy that would require insurance providers to accept doula and midwife services. And there's a lot of evidence that suggests that those resources work. Like, those are helpful in terms of creating a pregnancy environment, childbirth environment, and even beyond, because there's doulas throughout child development and child rearing. But there's a lot of evidence that suggests that it works. One of the issue I learned with getting it passed, particularly on the doula side, was that and I think this is another way that white supremacy operates, right? Because it's basically the doula is not organized. The insurance providers are lobbying that, well, if you want me to pay for doula services, then they need to be standardized, they need to be credentialed, we need to create a governing board, they need to be licensed, and all I hear is pay barrier, testing barrier, barriers that would prevent people of color and Black folks to be doulas, right? And so my answer is there's a lot of evidence that suggests it's possible, particularly when midwives, because insurances don't necessarily cover it, or it's not federally mandated, I should say that they cover it, it can be a pay gap for families of color. Yeah, does that answer your question? Wonderful.
Yeah, thank you.
Yeah.
Thank you, Rihanna. Now I'd like to introduce our second reflector. Deb Berglund has been the director of the Cape Cod campus for the BU School of Social Work since 2010. Deb is a 1994 graduate of the BU School of Social Work and has worked with disadvantaged populations for most of her social work career. Deb specializes in working with traumatized individuals, particularly those with generational trauma. Deb is an active member of the BU School of Social Work Equity and Inclusion Committee and has been a member of her town's Affirmative Action Committee and other community and town social justice initiatives for many years. She lives on the Cape with her daughter, who is heading off to college in the fall, and 2 rescued cats.
Thanks a lot, Ellie. Natasha, thank you so much for your presentation. I'm virtually speechless, which is not, anybody who knows me knows that that's hard to make happen. You're absolutely right. I have so many questions written down. I don't even know which question to ask you. So I guess we'll see as I give a little bit more of the reflection. But I so appreciate you talking about this intersection of disability and race and gender around health equity. It's just not something, sadly, that we ever hear about, particularly the issue of disability and race being talked about together on a regular basis. And you know, I was glad to hear you talk right in the beginning about the challenge to Roe versus Wade right now, and you know, and that obviously is a risk to all women, but I think when you add the intersection of disability and race to that, and all the statistics you shared, the risk for Black women and other people of color is just compounded immeasurably. I'm one of those people who had never seen the Australian map. So to see everything in my view be upside down, it was just such a great visual representation of the difference of perspective, and certainly how white supremacy can be put on something as simple as a map, and be taught from such a young age about how the world is and how the world should be seen. One of the questions that I had for you, and I have some ideas and I'll share them, but I obviously am more interested in your ideas than mine around this. But you had mentioned as one of your statistics, I believe that 70% of pregnancies of Black women are unplanned. And, you know, I imagined that statistic is coming from things like lack of access to healthcare, lack of access to reproductive services, some internalized historical and cultural beliefs around Black women's bodies not being their own, and around the effects of trauma on people, and again, internalized beliefs around the roles of Black women in the family and in society. But I'm really interested in your perspective on that statistic, and anything you'd like to add about that as well.
Absolutely. Thank you for the thoughtful reflection. Like really listening to you kind of summarize and put it back and give it back to me. I'm like, oh, I said all that. Wow, that made sense. Wow, I can't believe that came from my lips. So it's kind of a thank you. I appreciate that. In terms of your question, I think that's a good one. So your question is, and let me make sure I understand it, is why do I think that 70% of Black women's pregnancies is unplanned? Is that correct? Okay. So I think that we would have to really think about intimate partnerships between Black people, and particularly Black men and Black women, if we're talking very cisgender binary. So we're gonna get real specific real quick. But so if we really look at those relationships, right, there's a lot of historical problems that white supremacy has caused between those relationships, particularly when you're talking about education, employment, access to jobs. Well, I said employment, access to jobs. And what does that do to a people when your dating partner is, or your demographic of dating, in a lot of ways, sometimes can be unstable. And that's not everybody's situation, but it can be unstable. And coupled with those, yes, access to contraceptives, healthcare, planning services, who's working within those planning service organizations? What are their races? Do I want to talk to a white woman about me planning a baby with my Black partner? Right? Do I want to do that really? Probably not. Thinking about, do people get routine checkups and routine prevention services? And there's a disparity there. So I said that to say that you have a group of people who have been, particularly Black men, who've been over-policed, incarcerated, and put into a caste system where they are essentially stripped of a lot of resources, not all, but stripped of a lot of resources. And so as a dating prospect, when you're learning femininity, when you're learning womanhood, you're learning I need to be in a lot of ways taken care of. But at the same time, Black women are learning, I don't need that. I can't, like, I need to be strong. And so there are some competing narratives going on. And so I think, and this isn't my expertise, but I think that it may contribute to a culture where dating prospects are shifty. And then also you don't have the tools and the resources to make those decisions in a way that's in alignment with your goals. So I think there's a lot of different processes. If you remember my white supremacy concept model, there's a lot of different things happening at one time that's hard to pinpoint, but I would start with structural issues and how it affect like a group of people, like Black men specifically, and then like I wonder what that does to dating. But yeah.
Thank you
I
so
hope
much.
I answered it. I tried.
Absolutely. Thank you for that. And also thank you for just continuing to name white supremacy as, a linchpin in that process. So I really appreciate that as well.
Thank you, Deb. And thank you, Natasha, for such an excellent presentation. I'm going to take a few questions from the audience. These were questions that were typed in to the chat. And the first question is, who are some of the Black disability advocates and thinkers that you would recommend we read more about and learn more about regarding this issue?
Yeah, I think Sammy Chalk, she's a tenure professor now at the University of Wisconsin, Madison in women and gender, I want to say. And she has this fantastic book called Bodies Reimagined, where she really gets into the discourse of Black women, particularly those with disabilities and how they're excluded. Like, she has this whole other piece about disembodiment, where she talks about how if Black women are experiencing sexual violence at these rates, then it's duly connected to disability. When you think that 94% of people who have been raped or sexually assaulted experience PTSD. And so when you start to think about like mental health in terms of disability and the connectedness, it becomes more prevalent and more illuminated. So definitely her. There's also Moya Bailey. She coined the term misogynoir, which is the hatred of Black women, so kind of like misogyny. And she wrote this fantastic piece, actually, where kind of I got some of my pieces around the strong Black woman trope and fast and twice as good, that calls for a Black feminist disability framework. And then I would even go venture to say, if I'm getting into a bag, that if you look at some of the works of like Audre Lorde and Pat Hill Collins, it's the peculiar thing about disability in Black women is that we don't name it, but we talk about it. And so there's a lot of scholarship out there, and you have to be willing to engage in that scholarship without being able to see the search terms, without being able to like say, oh, this is disability, but really looking at the threads. What are they saying? Listen as you read. So I hope that's helpful.
Very helpful. Thank you. My next question from the audience, do you see a lack of data for folks of color who intersect with the LGBTQIA plus identities, non-binary, gender fluid identities in reproductive health and disabilities?
That's a lot. One more time, let me stroll.
And I know you spoke earlier about the lack of data that you were seeing with Black women with disabilities, but this, I think the intersection is also with our LGBTQIA plus communities as well.
I can say that I think an opportunity for filling in a gap in a lot of this maternal health research is frequently it looks at women, and it doesn't often include LGBTQIA folk. And so that's an opportunity to really fill in the gaps of the research. There's not a lot of research on Black maternal health. And so certainly there's not a lot on the intersection, like sexuality intersections within that. And so if that's something that you're interested in, I can't see who posed the question, but like, maybe we can write something.
And another question is, you recommended that researchers ask about disability as part of demographic data collection. What specific questions have you asked or recommended fellow researchers ask, given the wide range of disabilities and chronic health conditions?
So I've seen them lumped into categories in terms of like physical disability, intellectual developmental disability, and mental health disabilities. And then frequently you can kind of do a drop down. And then sometimes it's more of a, what's it called when you go to the doctor? Like almost like, have you ever had these things? And so I haven't necessarily recommended it for anybody, but it's something that I'm interested in developing, and I think would be a good conceptual piece to present at like CSWE or something.
Thank you. So another question is, And I think this will be our final question, is that right? We were really glad to hear you bring up a need for social workers to get more involved with efforts to bring policy changes. Few of our social work colleagues are involved in those types of efforts. Do you have any suggestions for encouraging others to get more involved in policy and politics as it relates to these issues?
Yes. So I will say my experience working with legislators is that they are super willing to like sponsor stuff. So much so, I met with one, and I feel like 2 years ago now, because of COVID been going on for a while. It was about COVID and hospital transparency in Louisiana for people with disabilities, or something about their policies. That's a diatribe. But so I met with the representative, and I gave my fact sheet. This is the problem. This is why. And she said, "Oh, this is great. You have any language? Like, what's the bill? Yes." And I was so thrown off and taken aback because I'm so used to people framing politicians in a way where they're not accessible, and many aren't, and they're not willing to support. But I was surprised, and for me, it gave me even more encouragement to reach out to other people. Like I said, I spoke to somebody about doula services in Louisiana. And so it's really easy. It's something great to put on your CV. It's easy because politicians can be sometimes they can be a little lazy now. But also part of it is that they don't know what the research is pointing to and what it's saying. And so if you can come with something proposed and written, a draft, then they're happy to get on board, particularly if their politics has shown that they would support something like that. So for instance, the person that I'm talking about, they sit on the State Health and Welfare Committee, and they chair the Women and Children Subcommittee. And so I knew that they would be willing to support, willing to engage, but I didn't know they would be that willing. And so I encourage you, try, just be the difference, because so many people don't, and they think that, an advocacy agency is going to do it, or, a lobbyist is going to do it, an advocate, but you can do it and put it on your CV, and that's some good stuff. And you feel good, right?
Yeah, I mean, I believe strongly. I know that the School of Social Work is always building upon leadership within our field. I think that, civic engagement is a remedy to addressing health equity. And so I'm really glad that you brought that up. I would like to thank you for your wonderful presentation. We thank everyone for coming, especially our wonderful speaker, Natasha M. Lee Johnson, especially our insightful reflectors, Rihanna Howard and Deb Berglund, and our amazing behind the scene tech social work doctoral student, Greer Hamilton. One more reminder is that if you are getting CEUs, you must complete the form using the link we just put in the chat. In the movement, we like to say that the path to justice is more like a marathon and not a sprint. Take good care of yourselves, everyone, because we need all of you to create our new world. We hope to see you at our next Equity and Inclusion Speakers event, Thursday, April 28th, when Dr. Sophia Sarantakas will present on nearing the abolitionist horizon through professionalized social change work. Thanks again, everyone, and onward in the struggle for justice and liberation. Have a wonderful night.
Fantastic job, Natasha.
Thank you.
You did amazing.